Perfeito, perfeito. Eu sei que André Mansano está sendo na cirurgia agora e vai.
Te vas a llevar una gran sorpresa, José Luis, porque como sabes, me gusta mucho el vino tinto,
Sim.
eh, pero descubro que si tomo vino tinto en la tarde, en la noche, no puedo dormir bien.
Ah,
Eh,
sim.
Eso es uno de los... Por cierto, ¿queréis que hable para el recording en español o en inglés?
Você pode escolher o que queiras. Sim, e fique à
No, yo
vontade. Estamos listos para o que pensas que é melhor. Sim.
para lo que queráis. O sea, me imagino que no todo el mundo entiende mi castellano. Para algunas personas es más fácil, para otros más difíciles. Sé que no pude atender, pero sé que Leo Caporal la última vez habló en inglés, así que lo que tú me digas, lo que tú crees que sea mejor
Sim.
para la gente.
Podes falar em inglês ou o que quero que fique como
Lo
se
que
fosse sua
decida
casa, amigo.
Cecilia, lo que decida Cecilia.
Cecília, pode
Ah,
escolher, por favor.
inglés.
Em
¿Inglés?
inglês,
Vale.
perfeito.
Okay. Okay. So, so let me tell you, José Luis, in terms of the wine that I was going to choose, my so my issue right now is that if I drink wine after 6 p.m. or so, I cannot sleep. I I
Oh,
go to
really?
sleep, but then I have a fragmented sleep. Hey, Angel, how are you? I am
Nice to see you
so
again.
nice to see you, Angel. Look at me.
Ah,
Nice,
sim.
nice.
I
Beautiful.
I
Hola.
I didn't know you were going to be here, Angel. I had no idea at all. But this will give a little bit of information of what I'm gonna be drinking tonight. And in fact, Jose Luis, it was you the one that walked with me to get my shirt
Guayabera.
at Guayabera in Merida. So I decided to put my Guayabera, and
Nice.
I was telling you, Jose Luis, that my problem with wine is that I cannot sleep at night. I have a
Hum,
little history with wine because um, my father migrated to Colombia when I was a little kid to make wines in Colombia. And he's from La Rioja, which is one of the uh, main vineyard areas in Spain. But I do prefer one that is called Ribera del Duero. It's in my mind is a little bit softer wine, so that's what I is my favorite wine. And I prefer anything that has to do with Vega Sicilia from Unico. There is Valbuena. There is Macan, which is the one that I was going to bring tonight. And it's because the Macan is Vega Sicilia, but it's made in La Rioja.
sim.
But again, if I do it, I won't be able to sleep. And even worse, because I can only drink a glass, then the rest of the bottle is going to be ruined. So I decided to go with something that I learned to love, and that over the last, I will say, maybe 6 months or so, I'm even loving more than before, and it's because I had a very interesting night in Bogota, in Colombia, with some of the Mexican guys that obviously requested tequila. And we were drinking tequila until probably 2:30 or 3 a.m. until they basically kick us out of the bar. And then in in Merida, which is where the last meeting that I attended, which is it was an spectacular um, visit. I mean, it was fabulous. I enjoyed everything about Merida. But the last night, they had an orchestra, and I I gave like $10 or something like this to the guy that was serving us. It's just because I like the guy. Well, the guy just was pouring tequila all night long in
Oh
my
my
in my cup. So I was
God.
drinking one tequila. The guy was absolutely sure that I never missed tequila. So I think everybody in my table got a little bit drunk. And I was
Yeah.
flying the next day, so I basically didn't sleep at all, and I ended up getting into the airplane. But so that's what I brought this tequila bottle,
Oh my
uh,
gosh.
which uh, is Clase Azul. I'm not an expert in tequilas, but let me tell you how I'm gonna drink it. I drink it in these little things that I got from a restaurant nearby, and I I had a friend of mine who puts ice in his tequila. I don't like to put ice in my tequila, so I'm gonna do something a little bit different that I recently discovered. As you can see, for those of you that are listening to the presentation or are listening to the recording, this is probably a little bit more interesting, at least for me, than talking about a particular topic. So what I have done is, this is a piece of granite,
Okay.
uh, and I put it in the
Yes.
refrigerator. So it's
Ah, really?
frozen, and
Oh my God.
I put it inside of my little thing so it doesn't get melted. By the way, sorry, I throw some ice in the floor. My wife would say that I always do that. Uh, okay, so so this is what I'm gonna do. I was hoping that you all will be drinking something more meaningful, but I just saw Cecilia drinking Coke. So it's a shame for you. But what I'm gonna do is I'm gonna put one little piece of tequila that is gonna last me all night. And I'm gonna pour it in this stuff. And here I am. I have my little tequila with a little holder that I put at the bottom. So
Okay.
so cheers, Jose
Cheers.
Luis. I hope
Cheers.
that somebody
Cheers.
else is drinking. No, not with you, Cecilia. What a
No,
shame.
Coca-Cola, no.
And Angel is not drinking anything. I
Yeah.
thought that
I'm
Angel
still
was
in
But
going
the
to be
yeah.
hospital.
inspired.
l-
No, they don't
the-
allow you to drink stuff in the hospital. Ah, what a
yeah.
shame.
Yeah.
Uh,
Ricardo, it's our second time we have tequila and pain tequila because
Yes,
Angel, yes, was the first one who made
yes.
it.
And
Yeah.
was a similar bottle. Was the same, the similar bottle.
Yeah.
oh,
I
wow,
love.
great.
Yeah.
I like Clase
Good
Azul,
choice.
and I have few, which is sad because when I go anywhere in the world that I go to give presentations, I never go with luggage. I only have my carry-on luggage, which means that unfortunately I cannot go to the airport, or I can go to the airport and buy something, but Clase Azul, they don't have it in any airport in Mexico in the duty-free area, which I think is a real shame. Felipe, it's a pleasure to see you. Um, for those of you that are listening to me speaking in English, it was because Cecilia decided that it was better if I
Yeah.
spoke in English, so I'm trying to do that.
She
Um,
chose that. Yes.
So I'm gonna start, Jose
Yes.
Luis.
Yes. Of course.
Mm,
Mm.
Now, something that I also realized about tequila. So I don't know anything about tequila except that I have one of the best experiences in my life with tequila. But I realized that it happened in Mexico. Apparently, the tradition is that there was a lightning strike in some of these agave plants, and it created like this fermentation. And the Aztecs used to drink it and call it the pulque. And then obviously when Spaniards were there, we're like, okay, we can distill this alcohol, and that's where the tequila came from because it was close to the Jalisco area. There is a town apparently that is called Tequila, which Angel has never invited me to. So probably next time that I go there, I can try to escape
Yeah,
to this area.
we need to
So
go.
that's a little bit what I learned about it. I also learned that this company was initiated in 1997.
Oh
which I
gosh.
thought that was kind of interesting because there is some collection bottles that are in the thousands of dollars. So how is it possible? And the owner of this land decided to make a tequila and created a beautiful bottle because he realized that people care more about the bottle than the tequila itself. So that's how this Clase Azul came up, and I enjoy it. And I hope that you all will have beautiful experiences with tequilas I have had, and that you have a Brazilian friend like the one that I had that told me how to get my shirt that day, so I didn't came empty-handed. So I think that is my introduction with tequila, and I don't know, I have
Yeah.
never made a presentation while I'm drinking tequila.
Yeah, yeah.
Mm,
Probably the
so it will be,
first time. Yes, you never forget.
well, I may forget. I hope that I don't say things that are not very unreasonable, so it will make sense what I'm gonna talk. So before I begin, I think I need to share my screen. Mm,
Yes, yes.
there is some people in the chat. Auditoría en español. Okay, aquí tengo, here I have somebody saying, en español, estaba más legal, which I
Sí.
suppose means that some people may like to have it in español.
Let's. Oh, so you need to follow Cecilia opinion, please.
That was Cecilia. She's the boss. I don't know. I
Yeah.
am just doing. Yo puedo hablar también en español, pero desafortunadamente Cecilia es la que decidió hacerlo en. um, Yeah, one thing, I'm trying to share my screen. I probably will
Yeah.
need somebody to give me permission to
Yes.
share my
Let me
screen.
see. Let me see. É, deixa eu ver. Kátia, está ouvindo? Você
Mm,
consegue autorizar
Estou.
o. Ah, consegue autorizar o Valerro?
I
Sim, eu
think I
coloquei
was
ele.
an author.
Ok.
Yeah.
Ok.
Can you guys see my screen?
Yes.
Yes. Yes.
Okay. So, before I begin, I wanted to show you all, I don't know if you can see that. That was a gaucho that was given to me the first time that I went to Brazil. And as you can, that was not planned, but as you can see, I have it in my studio. It's one of my dear pieces of art. So thank you all. Gracias a todos por estar aquí conmigo hoy. Como decía, Cecilia ha decidido que esta charla sea en inglés, así que le haremos caso. Eh, Antes de empezar, or before I begin, sorry, I would like to tell you a little bit of what I've been doing over the last 8 years. As some of you may know, I'm a clinician, number one. I think basic science, in my mind, the main relevance is if it can help patients. If not, I don't think there is too much value of what we do. I strongly believe that research, especially basic science research, should be conducted with the main purpose of understanding some mechanisms underneath different therapies in such a way that they can help us, this understanding can help us to provide a much better therapy for our patients. So for the last 20 years, I've been working mainly on molecular mechanisms at the level of genes, proteins, phosphoproteomics, and peptidomics, and how those molecular mechanisms can be influenced when we apply electrical signals. So at the same time, about 7 years ago, we started a project in my lab at Illinois Wesleyan University. And by the way, here is my conflict of interest. Hopefully it will come up. At Illinois Wesleyan University, we have been handling for the last almost 8 years research related to the evoked compound action potentials, which is the topic of this discussion. And what we are trying to understand is what is beyond the ECAP that I'm going to be talking about. And I hope that at the end, I will have a little bit of time to explore something that for me is relevant, and is where are we going from here? Some of you may have heard about ECAPs. We're going to talk a lot about ECAPs today, but I wanted to emphasize that probably what is more exciting to me is not the ECAP itself, but the rest of waveforms that we can visualize in the lab, and that one day may become the next generation of stimulation. And I think because of this open blanket, I hope that this will bring interesting discussions among all of you present here today, and hopefully it will also generate some curiosity by physicians that are going to listen to this presentation in the future. This is my conflict of interest. I will say, relevant to that, I have not only with DTM, which is a programming paradigm for spinal cord stimulation, but I also have several patents in terms of ECAPs and how those ECAPs interact with novel waveforms. I don't have any ownership of these patents. I already gave them away. So I think it's important that you understand that it's not really something very relevant for this conversation today. What I would like to start is to ask you all a question, and is, how do you often prescribe monohydrate lactose or talc or mannitol, magnesium stearate, or corn starch to your patients? I assume that some of you are thinking, like, what's going on here? Why is he talking about that? The purpose of this question is that I'm pretty sure most of you prescribe gabapentin. And those are the adjuvant compounds that are included in the capsules when you prescribe this medication. And I will argue that we as physicians typically prescribe therapies. We do not prescribe technologies. Those different compounds are put together so they can optimize the absorption of the medication, or the stability or biocompatibility of the medication. So I want you to understand something, and is that ECAPs, as far as are used currently in the clinical setting, are a novel technology. They are not a new type of therapy. So let's start by something very, very simple. Remember, we put the epidural leads in the posterior epidural space, and that's where we are stimulating. Our goal is to provide depolarization, therefore generation of parestesias in the dorsal columns, in those axons that are going up and down this epidural or this spinal portion of the spinal cord. So the ECAPs, spinal evoked compound action potentials, or electronically evoked potentials, are basically a sum of the axons. You are not measuring one axon generating one action potential. You are measuring the summation of these action potentials at one particular location at certain distance from the electrode that you are activating. So it's important to understand that you have two main areas within your electrical lead if you are using the ECAPs. In one of them, you are applying the electrical signal, so you have your stimulating electrode, and then you have an recording electrode. And this is very important because the recording electrode is going to be the one that is going to make or measure this summation. And this summation is in certain way a reflection of what is the total volume of tissue that is activated. And we know, and I'm going to briefly discuss that at the end, that there are multiple factors that can influence these ECAPs. from pharmacological agents, from the position of the patient, something very important, and one of the things that will be addressed based on the ECAPs. But there is also disease states that hopefully at some point we will be able to measure, and I will give you a little briefing about that at the end of the presentation. Now, if you think about a closed loop, it's not a novel idea. It was incorporated back in the 70s, where you have in the heart, you have recording electrodes that can measure the heart rate or the activation of the sinuses, and they can determine whether or not they will apply a particular frequency of stimulation. We also have something very similar in these cochlear implants. In the case of the cochlear implants, though, there is a major difference. Imagine that you put the electrical lead over the nerve, and on top of that, there is no CSF, there is no distance that will be modified when you are putting your electrode. And the last thing is that positional changes will not affect the distance between the recording electrode and the nerve that is subjacent to that. So I think this is very important. So we learned already that the ECAP is a reflection of the volume of tissue activated. If you think about what is happening with an ECAP, you are measuring basically a wave that happens at certain distance from where you stimulate it, and then at that location, the recording electrode is measuring a wave. The wave is composed by three components: peak 1, P1, the negative peak 1, N1, and the positive peak 2. So we have two peaks, peak 1 and peak 2, and in between you have a negative wave that represents the opening of the sodium channels, while the closing of the ion channels is measured by the P2. Once you determine, and this is very important, is once you determine the amplitude, which in this case is measured between the negative peak and the positive peak, if you measure this amplitude, this distance between these two portions of the wave, you can use that as a surrogate for the volume of neural activation. And based on that, you can determine whether or not you need to increase or decrease the amplitude. Keep in mind, this happens 50 times per second. So that means that every second, if you obtain an action potential, the next stimulation that you apply could be modified based on the closed loop. It even means that if you have an action potential based on the ECAP that is observable within the 50 seconds or the 50 pulses per second, you can modify dynamically what is going to be your next signal. This is just a study that I think is relevant because the ECAP was initially formulated to be used with tonic stimulation. And this is a study led by Nagy Mikhail, in which he looked at what is the difference between traditional stimulation, tonic stimulation in an open loop without recording an ECAPs and adjusting the next pulse, the amplitude of the next pulse based on the amplitude that you recorded, and then you can determine the difference between open loop or closed loop. They look at patients for a total of 3 years, and in the first 2 years, at 12 months and 24 months, they report around 80% of the patients having more than 50% reduction in their pain. So that means that the closed loop technology, when used as an adjuvant for the tonic stimulation, provides better results, significantly better results than when you use those for the open loop stimulation. But as we have some time, I want to dig a little bit deeper into the ECAP and what are the factors that will be affecting the ability that the system will have to generate the right ECAP, the right N1, P2 peak within the waveform. And this is important. As you can see here, I hope you are seeing my arrow in the computer, but here you have a patient that is sitting in the upright position. That is the first diagram here on the left. If you ask the patient to bend forward, backward, what you're gonna see is that the distance of CSF, the distance between your electrode and the dorsal column is gonna be smaller, which means that this amplitude that we are recording here for the wave is gonna become dramatically larger. As the patient goes back over time into the sitting position, you will see how, once again, in the sitting position, the recording is gonna be much smaller. So it has a major immediate clinical advantage. And is that if the patient coughs or the patients bend backward, and you observe an increase in the magnitude of the volume of neural activation because of the increase in the size or on the amplitude of the ECAP, immediately that is telling you that it's too short. And therefore you can adapt the next amplitude. So while the patient is bending backward, the next pulses are going to be at a lower amplitude, preventing the discomfort of the patients when they are in this position. And believe it or not, even in patients that have the traditional new paradigm in which the majority of the patients are not feeling paresthesia, even those patients, almost 50% of them, will be forced to increase or decrease the amplitude manually in their remote control of the amount of current they are receiving in order to be comfortable. Some of the patients decide to avoid certain activities. Some of the patients even go into a resting or protecting position to avoid this type of situations. Now, there is something that is obvious, but I think is important, probably one of the most important aspects of this discussion, which is the presence of artifact. You have to imagine that the noise created by the spinal cord stimulation, by the pulse, is way bigger than the amplitude of the waveform. It's like 1,000,000 times bigger, the noise generated by the electrical impulse, than the amplitude that you're gonna observe when you are trying to see the ECAP. And what that means is that here we have the magnitude of the impression. If you look at the left side, this is one of the patients that we did very early on, and you can see how the ECAP area is in this semicircle, and then you observe how the artifact will be getting closer and closer and closer to the area of the ECAP, depending on the pulse width. If you have a pulse width of 120, there is going to be a lot less artifact at the location where you are measuring your ECAP than when you are using a higher pulse width. What I'm saying here is that there is certain aspects that can modify the effect of the artifact. One of them is the pulse width. The longer the pulse width, the higher the chances that the artifact is going to be mounted on top of your ECAP. The other thing is the frequency. The higher the frequency, the closer or the less window you will have to read these ECAPs. And we're going to talk in a moment about this window because it's fundamental to understand the ECAPs. The second aspect that is important is that the farther away that you are from the stimulating electrode, the recording electrode will have a much better job at detecting the ECAP. So if you start moving your the stimulating electrode closer and closer and closer to the recording electrode, the smaller the window that you will have to measure the ECAP. And I've been talking about the window for a particular reason. Let's summarize a little bit what we were talking. The shorter the pulse width and the wider spacing from the stimulating electrode and the recording electrode, the better option you have to record the right ECAP. Why is that? Because imagine that you have a very, very noisy artifact by the stimulating electrode. If you have, you know what is the time of conduction, of depolarization and transmission of this depolarization from the neural tissues. You know the conduction velocity of the A beta fibers, so you can determine, okay, if I stimulate here, all this time, the summation, the ECAP, the summation of these action potentials is going to happen, let's say, in 1 millisecond. So during this first 1 millisecond, what you do is you close your eyes. The recording electrode is closed, is not receiving any artifact, and it only opens at the moment that the action potential is going to happen. Now, the challenge there is, how do I differentiate the remaining noise from the artifact from the actual action potential that the patient, that I want to measure in my patients? So this is some of the efforts that we started looking. This is the first study that was done in the ECOMAC. 14 patients were trialed with traditional stimulation. And at the end of the trial, the patients were asked if we could do in-house stimulation and measuring of the electrodes. And you can see here on the top part of this image, here you have in the caudal portion of the lid, you have the stimulating electrode. Here you have probably your cathode stimulation. And here distally, you have your recording electrodes. And there is this gray area, which is basically not seen by the recording electrode. The recording electrode is basically off, and it will open right here when it is assumed that the signal is gonna be the ECAP is gonna be able to be perceived. So here you have you totally obstruct the vision in this artifact area, and then you get only the neural response. Keep also in mind that something interesting is happening. The amplitude of the noise generated by this stimulation is decreasing exponentially as you go farther and farther away from the stimulating electrode, while the depolarization of the neurons is starting to grow at a very, very small amplitude compared with the artifact, but it's going exponentially high while the other one is decreasing. And this is the key on how you can detect what is the stimulation. So doing that, we were able in these patients to observe the ECAPs, artifacts, which were particularly prominent in the spinal cord. We were able to reduce that. And we also observed that very large, that's kind of obvious. I talked already about the frequency, the pulse width, but another very important component in the artifact is the intensity, the amplitude of your signal. If you have a very high number of milliamperes when you are applying the electrical signal, the chances that your ECAP is going to be confounded with the ECAP is even higher. So let's look at different methods, and I will tell you only why am I bringing this on right now. So there is basically 4 ways that you can stimulate or you can detect the ECAPs. The first one is the one that I just mentioned. You have certain area that you take out of the wave. You just simply knock this out, and you are trying to detect what is the ECAP, what is the wave, this triphasic wave in the spinal cord that represents the ECAP. The other one is the high pass or the correlation methods. And I'm mentioning these two because those two are the only ones that are currently clinically available. The last one is you create a template. You know how the ECAP should look like. So then you create a template, you take the artifact portion out, and then when you record a wave, if this wave is similar to the template that you have, then you decide this is an ECAP. What is the problem with that? Imagine that for whatever reason, the artifact, when you open the recording electrode, looks like your template. That means that you're going to consider this particular artifact as an ECAP. And that means in a closed loop stage, it means that the next signal that you apply will be titrated based on that amplitude. In the high pass, what is done is you observe, you take out the artifact portion, but then you observe what is the logarithmic increase in this waveform. If it increases, instead of being decreasing as the artifact is doing, then you validate that that is an ECAP. And this is the method that I'm going to be talking about from now on. This is again a template that is used by one of the only two companies that are using ECAPs for the closed loop and therefore the titration of the signal. And this is how they use, in this case, they have this white, I don't know if you can see, this white wave, that is the template. And if the signal that they observe, this wave that they observe is similar, then they conclude, well, the system concludes that is an ECAP, and then it will determine what is the next pulse that is going to be applied. Now, and this is the other method that I was telling you, which incorporates real-time evaluation, and you observe the amplitude, the logarithmic increase in the waveform before you determine whether or not a particular wave or triphasic wave that you are observing is or not an ECAP. So the therapy so far has been mainly studied using tonic stimulation. So it's basically the same type of stimulation that we have been using for many times, but it has the large advantage in the study shown by Nagy Mikhail that the amplitude will be titrated. So you will avoid many patients that will reduce the amplitude in order to be comfortable, and therefore they will have a much better results with the therapy. The big question is, can we incorporate these ECAPs, this marker or biomarker of the volume of tissue of neuronal activation? Can we use it in combination with novel therapies? And this is what we have been working in our lab for the last 8 years. You can see, first of all, our model, the animals are at some point anesthetized. They have the pain model that we have been working all the time, but then we are using only 6 electrodes to stimulate and record the amplitude of the ECAPs. So this is just a very simple initial study that we did in which we measure the ECAPs. As you can see here, in the first stimulation current, because the amplitude is so small, you cannot see ECAPs, or you cannot see the visual movement of the leg in the animal when you are stimulating, or you cannot see the electromyographic stimulation. We put some electrodes within the muscles of the animal, and we were trying to detect whether or not these amplitudes that we were changing had an effect on the recording of the ECAP, on the recording of the electromyography, or on the visualization of the movement of the animal. As you can see here, you can start increasing the amplitude, and as you start increasing the amplitude, you start recruiting fibers, you finally get the ECAP. Higher amplitudes provide higher ECAPs until you also start visualizing. So first of all, the main reason that we did that is we wanted to figure out what is the amplitude in an animal model that represents subparesthesia stimulation. Something that is fundamental for the rest of the conversation is that if you do not have action ECAPs in an animal model, the animal does not have paresthesias. And that also applies to humans. That means that if you get an ECAP, that means the patient has some form of paresthesia. Why is that important? It is very important because that means that in the new paradigms, if I obtain an ECAP, that means that this patient is feeling parestesias. And remember, the new paradigms like HF10, like burst, like DTM, what we are trying to do, part of the programming is to avoid parestesias. I always said that for the last 15 years or more, parestesias are a side effect of the stimulation. They are not the target in your therapy. It's like if you prescribe heterocyclic, tricyclic antidepressant. Let's say you prescribe Pamelor or something like this. What you want to do is reduce the patient's pain. Now, some of them will make the patient sleeping at night, but that is not your objective. It could be beneficial, but it's not your objective. The same thing here. Some paresthesias may be beneficial because of the placebo effect that they generate in the patients, but they are not the purpose of your therapy. So here is what we did. First of all, we call our pulses. If you are familiar with DTM, we have 4 pulses that are run simultaneously. Our original animal studies use 2 separate signals, but we divide the slow pulses, the 40 to 80 hertz pulses, we call it the pinging because it pings, it gives the signal that you are going to be measuring. I have 3 more signals, but those signals, remember, one of the main issues is that they are going at high frequency. Therefore, getting the windows where you're going to try to see the ECAPs are really, really important or really difficult. So what we use is we use a low frequency signal, the ping signal, so we detect at that particular frequency, we detect the ECAPs. And this is what we have been doing. So this is some of our initial experiments. We have 20 milliseconds in between pulses, and we are recording the ECAPs. And look what happens in one of the first subjects that we did. Here you have a patient that is, you just start seeing the amplitude that the patient is perceiving, and then suddenly you see this marked increase in the amplitude of the ECAPs, because the patient at that particular moment, this event 1 is the patient cough. So the patient cough, and you can see how the ECAPs immediately go up, while the amplitude of the signal remains exactly the same. What happened during this period of time? The patient was very uncomfortable, but couldn't do anything to prevent this sensation. Here, though, we do the closed loop system. We have, once again, the event 1, the patient coughs or bends, and the patient maintains exactly the same perception. The patient is not uncomfortable. How do we do that? The closed loop, once this increasing amplitude of the ECAPs is detected, immediately will reduce the amplitude of the electrical signal until the event is gone, and then it will slowly going back into the similar amplitude that had before that event. So this is what we have been doing. This is what is done in the majority of patients right now, is that we have 2 programs. One is the pinging that is going to measure the ECAPs, but then we have the other 2 or 3 signals that are a slave to the first one. What does it mean? It means that if the pinging signal detects a very high amplitude, this signal is going to reduce, but all the other higher frequency signals will be reduced as well. Here you have an example. Here you have an open loop, so therefore different events are happening, and you can see how there is these peaks of the patient, but the amplitude of the signal for both, for the ping and for the interleaved signals, the higher frequency signals, we call them priming signals, they are exactly at the same amplitude. When you close the loop, when you allow the system to inform and provide a feedback to the next amplitude, you can see how all these peaks are dramatically reduced, but also the amplitude that the system is providing to the spinal cord is also modulated in the lower signal and in the larger signals. Is it relevant? That is, we are getting almost to the end, so I'm almost finishing my tequila. It is relevant. You may know that there is right now 3 randomized controlled trials with the use of DTM, and there is 1 prospective multi-center study with 50 patients for cervical stimulation. And the other 3 that I mentioned are for axial and radicular low back pain, some of them for PSPS1, and the last 2 studies for PSPS1, the first study for PSPS2. To summarize all these studies, all of them were multi-center randomized controlled trials. One of them was executed in Europe. The other 2 were executed in United States. All of them had more than 100 patients. All of them, patients reported 80% of the patients or more reported at least 50% relief. And in all the studies, 7 out of 10 of the patients reported more than 80% pain reduction. Secondary outcomes like Oswestry Disability Index or quality of life by EQ-5D, all of them also showed at least double what is a MCID, the minimal improvement in clinical response from the patients. Those studies did not use ECAPs or the closed loops. This is the first study. It was done in Australia, and at this point, it had more than a year follow-up, but the results are pretty similar. What is interesting is that the primary objective is what do the patients prefer at 1 month of the stimulation? Do they prefer closed loop or do they prefer open loop? For that reason, patients were taken to the office, and then in the office, they were offered both options. The large majority of patients, all of them prefer to have the closed loop than the open loop. So that is by itself a significant difference between what the patient prefers. Now, in terms of response, the patients were offered to use open loop or closed loop, and except 7.7% of the patients that use tonic stimulation with the open loop, the large majority of the patients use the closed loop DTM with 4 signals, or in 7.7% of the cases, they use the closed loop with 2 signals. The patients had a significant improvement in the level of disability of whether or not they were crippled, as 86% of them were at the beginning. And once again, 80% of the patients obtained at least 50% reduction in their level of pain. As we are getting to the end of the presentation, I wanted to discuss what we are working in the lab right now. I know that you all are interested in the ECAP and what are the implications. I think I gave you a relatively deep presentation on what the ECAPs are, but again, I've been working on that for the last 8 years in the lab, and some of you will be like, okay, so yeah, the patients do better. So is this the next generation? And it probably is for your patients, the next generation. But I just wanted to give you a little bit of a view of what we are working in the lab with. First of all, we want to understand how the latency, the time between the stimulation and the source of this triphasic wave, how does this latency is affected by the use of different medications. Many of your patients may be using simultaneously with the stimulation, they may be using ketamine or nicotine or gabapentin or other opioids. So we have almost 10 different medications that we are measuring or are providing to these animals, including alcohol. They really have fun, these animals, with the alcohol. And then we determine how these different systemic drugs affect the amplitude and the latency of the ECAPs. The implications is that it can serve in the future as a surrogate of systemic levels of particular medications. That, I think, by itself is quite interesting. This is a study that is right now done in Newcastle by Dr. Ibora. She has been there is 2 large centers that are working in animal models for ECAPs. One is my lab at Illinois Wesleyan University. The other one is in Newcastle. And this is the latest work that they are doing. We have observed for the last several years something that is called evoke synaptic action potentials. And I will go a little bit in detail what other waveforms we are observing. At the beginning, we were just trying to detect if we could or not these ECAPs. But as we move along, we are observing that if you wait a little bit longer, if you leave the recording electrode in the same location, but you wait longer, you may start seeing some other effects. And this is the first portion of the study. This is an animal that is implanted, and those are the electrodes that span from L1 all the way down to T6. And here you can see how you measure different pulse widths. And as you move the pulse width, you start seeing how at the same location, as you move farther away from L1 here in this area, close to the stimulating electrode, and as you move farther and farther and farther away, the amplitude of the ECAP reduces. So that means that the farther away you are from the stimulating electrode to your recording electrode, the amplitude starts decreasing. This is that the propagation of the signal decreases as time goes on. But this, as I mentioned earlier, this ECAP reflects the summation of the synchronous activation of A beta fibers in the dorsal column. And they have this P1, N1, and P2, and then you can determine the volume of tissue activation between the amplitude of N1 negative peak and the second peak. The advantage of that is that it serves as a pragmatic real-time biomarker of what is the activation of the system and allows a dynamic response based on that, based on the closed loop of that. These are the earliest signal from neuronal involvement that we can detect in the spine, and the duration of this pulse is about only 1 millisecond. I don't know if you can see this part of the screen where I'm circling with my arrow. But if you start waiting a little bit longer, and instead of measuring right there at L1, you start going a little bit distant. You start going to T10, T9, T8, T7, T6. So you are going in this direction. You will observe that a new wave appears. That is called doublet or secondary or tertiary ECAP. And it is different from the ECAP. So the physiologic effect that leads to this action potential is different from the first one that at this point has disappeared. The hypothesis is that it reflects postsynaptic dorsal column fibers. And this is activation of the pulses or synaptically after the pulse is given to the patient. So keep in mind, here we have something totally different. The ECAP has disappeared or is starting to disappear, and then suddenly you start looking at a second or third waveform that is postsynaptic, and it may represent the activation of spinal projection neurons and is the output from endogenous processes within the spine. So that means that it could be a modification or a marker of this dysregulation of these pathological nociceptive pathways that has happened in pain patients. And it could determine also that maybe if those waveforms appear, is a sign of a side effect or that the spinal cord stimulation system is no longer effective. It is a propagating signal just as it was the ECAP, but it takes longer. By the time the N1 ends, it takes about 1 or 2 milliseconds extra for you to be able to detect that. And interestingly, it becomes greater as you get farther and farther and farther away from the spine. So it's something that we are evaluating, and we are trying to determine whether or not these signals have any particular benefit with the use of pharmacological agents or if they are related to the success of the therapy. And finally, something that is, I would say, at least as interesting as the other one is the the source of a different type of activity. Here you see what is called the S1. This S1 is another portion of the signal, but this one is not propagating. It always appears exactly at the same time, exactly the same time frame that you are expecting it. So it is around 3 to 4 milliseconds after the N1, the negative peak of the ECAP. And it seems that represent the synaptic activity, but at the level of the dorsal horn. You will wonder, how do you know if it is the dorsal horn or if it is the dorsal column? Well, the reason is because several experiments in the past show that if you use glutaminergic antagonist for the NMDA receptor, you will observe a reduction or almost disappearance of these ectopic synaptic signals. And that is extremely interesting because potentially we could be evaluating what is the synaptic response that you are obtaining once you apply electrical signal. It may also represent aberrant spinal circuitry. For example, are those different in animals that have pain versus those that do not have pain? And that will provide a more dramatic understanding of the pathophysiologic conditions of pain and how any type of therapy that we apply could have or not certain effects. So this is, in my mind, what the next generation of technology is going to be within the field of spinal cord stimulation, and whether or not they're going to be relevant to improve the therapy or to be an adjuvant for other forms of therapy is something that hopefully we will see within the next 5 to 10 years. I think it's important to summarize and mention that our understanding of pain has dramatically changed over the last few decades. It became a total neuronal response, and now is more of a neuroglial interaction, is more a neuroinflammatory process. And I think this is important. It's something that we are working, how these waveforms that I mentioned correlate or not with different patterns of molecular expression. As a therapy, we need to understand the therapy, but we also need to optimize the technology. And something that is even relatively new, I would say it hasn't been in the market for more than 6 years, 5 or 6 years, there is a new movement at the level of basic science in which we are trying to better understand the technology and how this technology can better mingle or interact with the understanding that we have right now of the molecular effects of the therapy. And by doing that, we will hopefully be able one day to have maybe not even invasive recording electrodes that will provide us, based on AI, what is the benefit of the different therapies to our patients. I think I will conclude with that, and thank you very much to all.
Thank you, Vallejo. Thank you so much.
¿Podemos hablar español o Cecilia todavía está?
Sí, sí, sí. Por cierto, amigo, eu vou fazer pequeno announcement em português. And, congratulations before everything, because you are a great speaker and you are clear enough to us. And, eu quero agradecer ao OMED, que é o nosso patrocinador principal, e todos os participantes aqui, e anunciar aqui que nós estamos atingindo aí a cerca de 15 países. Hoje é o nosso canal aí praticamente de dolor é o canal mais forte em todo o mundo hoje, de movimentação de várias línguas e várias pessoas conhecidas aqui do mundo da dor. Valeu, felicitação, uma charla muito especial. Eu tenho uma pergunta no final do meeting para você, muito particular, sobre uma coisa que você disse sobre a região de Ribeira del Duero. Pero que antes vou falar pouco de spinal cord stimulation. Mira, yo comprendí que lo ICAPS trabaja haciendo un reclutamiento eh, e que usa múltiplos parâmetros, tanto amplitude, quanto intensidade, quanto frequência. E isto está correto? Ou há um parâmetro que ele usa mais do que outro? E entendo que podemos ter infinito trabalho no futuro, porque é uma terapia com muitas possibilidades de evolução para hacer múltiplos tratamentos. Você pensa que este recrutamento envolve muito mais coisa, como as estimulações das células de las glias? O que pensa mais sobre este ICAP? Por favor.
A ver, primero, todas las señales que tú aplicas a la médula espinal, por ejemplo, la estimulación tónica tradicional, nosotros hicimos un estudio en el 2013 en el cual observamos que utilizando parámetros tradicionales había una activación de procesos inmunes y procesos neuronales. Y para lo que hicimos fue en aquel momento usábamos una técnica llamada microarray en el cual observábamos todos los genes conocidos, lo que llamamos genes, que en realidad son codones que nos permiten, la antigua definición, son codones, o sea, un triplete de nucleótidos que nos permite generar un aminoácido en particular. Entonces, utilizando este microarray, observamos que había ciertos procesos neuronales que eran downregulated, mientras que había procesos inflamatorios a nivel de generación de citoquinas, activación de microglías y otra serie de elementos, los cuales se les daba una upregulation. Si tú lo miras, eso fue un poco lo que en aquel momento nosotros ya llevábamos aproximadamente 10 años estudiando la parte molecular, pero eso fue casi como algo que jamás se me había a mí ocurrido. Yo siempre pensé que las corrientes eléctricas tenían un efecto en todas las células que están bajo la corriente eléctrica. Es bastante obvio, o sea, no existe una corriente eléctrica que diga voy a dar curvas y voy a solamente a coger las neuronas. Ahora, la implicación es tremenda si lo miras, porque la parte del downregulation de los procesos sinápticos, de la intercomunicación neuronal que observamos, se correlaciona con el Gate Control Theory. Pero la segunda parte, en la cual observábamos una activación de procesos inmunes, en cierta forma me daba a entender que una posibilidad por lo que los pacientes no respondían a largo término con el uso de la estimulación open loop tónica es porque el efecto sobre la teoría de la compuerta era cierto, había una inhibición de esa comunicación neuronal a través de las fibras A beta, pero que a su vez esas mismas señales estaban activando procesos neuroinflamatorios que eventualmente llevarían a que hubiese un desbalance y esos procesos neuroinflamatorios serían más intensos que los efectos marcados por la estimulación neuronal. Es muy interesante, unos 3 años después, el grupo de Jun Wan en John Hopkins hizo exactamente el mismo estudio, pero ellos utilizaron microRNA, que es algo que a partir de ese momento nosotros también hemos estado utilizando. En este caso ya estamos midiendo todos los nucleótidos, los billones de nucleótidos disponibles y ya podemos observar diferentes tipos de codones, algunos de ellos que son non-coding RNAs y cosas de este tipo. Y ellos observaron exactamente lo mismo. Entonces, lo primero que quisiera aclarar, José Luis, con respecto a tu pregunta es, cualquier señal que tú apliques, puesto que la mayoría de las células que están bajo tu campo eléctrico son gliales, tienen un efecto sobre las glías. Ahora, ¿ese efecto es beneficioso o no? Nosotros sabemos que con el DTM podemos obtener una respuesta en animales, no en humanos, debemos tener una respuesta en animales y que esa respuesta en animales parece que tiende a revertir el efecto patológico que ocurre en el desarrollo del dolor crónico neuropático. Eh, si yo estoy seguro que todas las demás, de las demás señales también tienen un efecto, falta por demostrar si son beneficiosos o no. Pero la pregunta es, si tú miras el DTM tradicional, no usa los ECAPs ni el closed loop. Y eso es lo que yo traté de enfatizar. Los primeros estudios a gran escala que se hicieron con el ICAP no incluyeron el uso del uso del closed loop. ¿Cuál es la ventaja teórica de utilizar el closed loop? Nosotros, si tú miras, por ejemplo, el DTM, el concepto es muy sencillo, si no, no se me hubiera podido ocurrir a mí, supremamente sencillo, y es que diferentes componentes de una corriente eléctrica tienen diferentes efectos en diferentes poblaciones celulares. Es decir, la amplitud del pulso, la duración del pulso, si es la recarga activa o pasiva y la frecuencia. O sea, esas cuatro variables tienen un efecto. Y puesto que quizá la más relevante, y eso lo publicamos, como diferentes amplitudes tienen diferentes efectos moleculares, si tú tienes, gracias al closed loop, tú tienes una corriente consistente, tú esperarás que el volumen de tejido neuronal, neuronas y glías, que están activados va a ser más consistente. Y eso es, si tú miras, por ejemplo, qué se hace ahora, qué es lo que estamos haciendo en este momento, nosotros tenemos esta señal de ping que está por debajo de la percepción. Es decir, yo voy, por ejemplo, a un 85 a un 80% de la amplitud requerida para la generación de un ICAP. Si aparece un ICAP, quiere decir que el paciente puede sentir algo. Y eso quiere decir que el siguiente pulso va a ser más bajo. No sé si me entiendo, es como un acelerómetro. En cuanto yo veo un ICAP, yo bajo la frecuencia, que es totalmente diferente de lo que hace el ICAP para otras señales, porque ellos tratan de optimizar la amplitud para que siempre sea confortable dentro de parestesias. Nosotros, en cierta forma, tenemos todo el sistema diseñado para que si se detecta, inmediatamente se baje la amplitud. Y lo que es interesante en el estudio de Australia es que los pacientes prefieren eso a tener estimulación tónica.
Gracias. Ángel,
Sí, bueno, felicidades por la presentación, por el tequila, por la guayabera, todo increíble. Muchas
Mérida.
gracias por compartir toda esta información. Y a mí me queda mucho la duda también de otras tecnologías como por ejemplo la estimulación periférica, que también es como algo más nuevo a la parte tradicional, ¿no? De la estimulación de cordones posteriores. Si habría alguna posibilidad de combinar este tipo de terapias. Quería aprovechar, ya que nos dio la plática, para saber su opinión también de la estimulación periférica y si hay algo de esta investigación también para nuevas terapias.
Bueno, si estamos hablando de la estimulación periférica, cada vez hay más estudios, algunos de ellos aleatorizados, con más o menos calidad, sobre el uso de estimulación periférica. Yo fui parte del primer estudio de SPR que era diseñado para mononeuropatías y estimulación por 60 días. Millennium Pain Center siempre se distinguió por ser uno de los centros a nivel mundial que más pacientes traía en los estudios. Después de 3 años teníamos 3 pacientes. Es decir, al menos dentro de un estudio homogéneo, no hay muchos pacientes con mononeuropatía. Es más, uno de los usos actuales de la neuromodulación periférica es para dolores nociceptivos inflamatorios, como puede ser el dolor de rodilla, en el cual pues varía un poco el concepto porque no estoy tratando de modular las señales aferentes a la médula espinal y a mí me parecería más interesante de alguna forma bloquearlas, no modularlas. Pero claro, con la cantidad de targets que se han descubierto, algunos estudios hablan de 10, por lo menos nervios que van a la rodilla, pues es bastante difícil hacerlo. Me parece un poco, primero, para mononeuropatías, que es donde se quería utilizar primero, no hay suficientes pacientes para que una casa comercial le parezca interesante el uso de esta terapia. Entonces, de alguna forma, están buscando expandir las aplicaciones y una de ellas, pues como hay muchos pacientes, es la rodilla. Ahora, ¿tiene sentido? Pues yo te diría que no, pero la gente lo está usando y la gente reporta, a mí me reportan amigos que los pacientes les va bien. Ahora, eh, tengo ciertas dudas con respecto a eso. Ahora, quisiera hacer un pequeño paréntesis con respecto a un estudio que hice hace muchísimos años, a 2010 o un poco antes, en el cual nosotros hacíamos estimulación pulsada, que es una forma de neuromodulación, al menos eso se cree, en que nosotros estimulábamos el nervio ciático proximal al corte del nervio tibial y peroneal dentro de nuestro modelo del SNL. Lo que fue muy interesante es que los cambios que se observaban localmente donde se aplicaba, estoy hablando de cambios moleculares a nivel de TN-alfa, interleuquina 1 beta, receptores de serotonina, receptores de de GABA, todos esos cambios se observaban a nivel del nervio, donde estábamos aplicando la corriente, pero también se observaban a nivel del ganglio de la raíz dorsal y se observaban a nivel de la médula espinal. Yo no quiero decir con esto que una estimulación de un nervio ulnar, por ejemplo, deba su beneficio a que haya cambios moleculares a nivel más proximal. Pero definitivamente creo que no hay, y eso es algo que yo traté en mi vida, digamos, profesional, lo que siempre traté es de, si voy a hacer algo, quiero entender por qué. Y hay muchísimos temas en dolor de los que podemos hablar y extendernos, como las células madre, como otras muchas cosas, en que se podría preguntar, ¿pero por qué? O sea, alguien que me explique por qué funcionaría. Yo aquí veo ese problema, veo el problema que tenemos una tecnología, la queremos utilizar para todo el mundo, pero no sé si tenemos una clara, entendemos claramente cuál es el mecanismo de acción. Y como dije al comienzo de esta charla, para mí, yo no, por ejemplo, si tú a mí, Ángel, me invitas, oye, ¿por qué no te vas a arreglarme el coche? Yo te diría, por favor, Ángel, no me dejes abrir el capó de tu coche porque te lo rompo, porque no tengo ni idea cómo funciona eso. Entonces, creo que como médicos, quiero pensar después de los años, me he vuelto más sarcástico con el paso de los años, pero quiero pensar que en nuestra desesperación por ayudar a los pacientes, a veces hacemos cosas que no tienen mucho sentido. Entonces, ahora hay un boom con el peripheral nerve stimulation, que funciona, sí, como la radiofrecuencia pulsada funciona, sí. ¿Para qué? Eso ya no lo sé. ¿Podrían combinarse? Sí, se podría combinar la estimulación medular, la estimulación del ganglio de la raíz dorsal, periféricos. Me imagino que en un paciente en particular que la estimulación no cubra un segmento, ¿por qué no? Podría ser interesante utilizarlo, pero sabiendo y diciéndole al paciente que estamos un poquito allí tratando de pescar, ¿no? No tenemos ni idea qué va a salir. Así que... Pero me he vuelto también muy, lo decimos en Estados Unidos, muy opinionated. Antiguamente no era tan opinionated, entonces quiero pedir disculpas. Tengo un tequila encima y a veces quizá por eso hablo de esta forma.
Muchas gracias.
Sí.
Muchas gracias.
Nada, a ti,
Sisa,
Ángel.
Sisa.
Yo no hablo bien el español. eh, that's why I asked you to talk in English. But
You need a tequila, Cecilia.
Sí, sí, por certo.
pero I promise next time yo voy a hablar español. Pero me encanta la medicina translacional, eh, cómo trabajar dentro del lab, hacer las conclusiones, experimentaciones en los pacientes.
¿Quieres hablar en inglés para la pregunta?
Okay.
Okay.
So I would like to know if how can you, as you work in your lab with the ratitos, cómo hacer las conclusiones in your patients for this?
Te puedo contestar en español, lo digo por si la gente
Okay.
prefiere. Básicamente, si tú miras a mi investigación, yo empecé mis primeros pasitos haciendo investigación fueron al año 2001, 2002, en que yo estaba evaluando la inmunosupresión mediada por opiáceos y cómo la modulación del sistema autonómico podía tener un efecto beneficioso para impedir esta inmunosupresión en opiáceos. Sin embargo, observé que en mi práctica clínica, la mayoría de mis pacientes yo no les ponía opiáceos. Por lo tanto, para mí la investigación, como decía al principio, tiene que tener, primero, tiene que estar guiada por la curiosidad, número uno. Esa quizá debería ser la única forma, pero en mi caso particular, mi sesgo, my bias, es que quiero que mi investigación tenga una aplicación clínica. Y si tú miras, si tú lees toda mi investigación a lo largo de los años, te darás cuenta que hay un grandísimo sesgo. There is a big bias. Because yo lo que estoy haciendo es reverse translational research. That means que yo empiezo por el assumption de que spinal cord stimulator works. Does it work? I don't know. My null hypothesis should be, I have to prove that it doesn't work. Pero porque yo asumí que funcionaba. Entonces comencé a hacer todos mis estudios tratando de demostrar cambios objetivos de la estimulación. Y eso ha guiado desde el año 2001 hasta hoy toda mi investigación. El tratar de que ese reverse translational research tenga una aplicación clínica. Entonces, ahora, por ejemplo, vamos a comenzar a hacer estudios con fármacos para CSF infusions, pero es bajo la misma constancia. O sea, entiendo que tenemos un beneficio de esa terapia y por lo tanto quiero sacarle beneficio a la misma. Creo que sí funciona porque he visto que hay cambios moleculares. He visto que esos cambios moleculares se traducen cuando los usas de una forma relativamente racional, se traducen en mejores efectos en los pacientes. Quiero decir que mi terapia no es la mejor, ni muchísimo menos, es simplemente lo que a mí se me ocurrió, considerando las limitantes que tenemos porque funcionamos en en un mundo de frecuencias. O sea, we are in a time domain. So, in a time domain, en un dominio de tiempo, yo solo puedo poner X número de pulsos. Sin embargo, nuestro brazo, por ejemplo, la señal para yo mover mi brazo, funciona en un frequency domain, en un dominio de frecuencia. Es decir, yo creo ondas por la sumación de diferentes señales que hacen que a una particular frecuencia esto produzca la elevación de mi brazo. Es algo que he querido investigar, pero desafortunadamente tendría que usar armónicos de segundo, tercer, cuarto grado para replicar la naturaleza. Burst dice que replica la naturaleza. Yo, con todo el respeto del mundo, diría, tú mira un electroencefalograma, muéstrame un burst y luego enséñame lo que se llama burst. Y si a alguien le parece que uno se parece al otro, pues nos tomamos otro tequila, porque es que no hay manera.
No.
Pero quiero decir, dentro de eso, yo tenía que utilizar parámetros dentro del time domain que podemos utilizar hoy en día. Cambiarlo a un frequency domain, que es uno de mis sueños algún día, ocurrirá en 50 años porque hay regulatory agencies like FDA, like CE o EMA que no lo van a permitir por ahora. Entonces, pero hay muchísimo, o sea, lo malo de hacerte viejo es que vas a tener menos y menos tiempo para explorar preguntas que son fantásticas, pero tú, Cecilia, que eres tan joven, seguramente que lo podrás hacer.
Sí.
Gracias.
Gracias. Vallejo, una pregunta prática. Vamos a empezar acá en Brasil, probablemente no final del año, o ICAPS, here. Queria saber o seguinte: quando hacemos um ajuste de neuroestimulação, normalmente hacemos com o paciente deitado todo o tempo para ter um ajuste mais preciso, independente de se usamos um burst ou se usamos uma estimulação tônica, um DTM, prefiro fazê-lo deitado. E como o
¿Prefieres hacerlo
ICAPS
cómo? Perdona, prefiero
deitado,
hacerlo
lay down,
acostado, vale.
Acostado.
acostado, sí.
Vale.
Mira, y como ustedes en ICAP hay este ajuste automático, usted hace lo ajuste de la programación con él también acostado o busca en cualquier posición.
No, mira, te voy a decir primero, antes de contestarte, a ver si me acuerdo, porque ya me tomé un tequila, pero antes de contestarte, quería contestarle a Francisco, a quien le agradezco que me haya preguntado. Eh, Él lo que está preguntando es si esta variación del ICAP en que la detección hace que baje no podría utilizarse con otros, como por ejemplo el burst o el high frequency o algo así. La respuesta es sí, y yo tengo las patentes de eso. O sea que si quisiera se podría utilizar, básicamente con la misma idea de que si se llega a sentir algo, entonces se bajaría la amplitud. Yo también escribí un artículo con High Frequency Stimulation, con 10 kHz, en el cual demostramos, es una discusión totalmente diferente. Lo que pasa es que yo me pierdo en temas, entonces, pero si hablas de High Frequency Stimulation a 10 kHz, la amplitud que se usa es alrededor de 2,52 miliamperios. Si tú conoces la curva de Strength Duration Curve, la curva de fuerza-duración, eso quiere decir que a los 30 microsegundos de pulsos que utiliza el 10 kHz, para poder hacer eso, si tú quisieras hacer una depolarización neuronal, tú tendrías que utilizar amplitudes de aproximadamente 10 milihercios, miliamperios. Es algo imposible. De hecho, hicimos un estudio con David Abejón, un gran amigo mío, en el cual vimos que si tú quieres tener percepción de estimulación, a medida que tú aumentas la frecuencia, se hace muy poco placentero para el paciente. Es muy eh, uncomfortable, muy poco confortable. Yo tampoco hablo ya muy bien ni el español, ya no sé ni lo que hablo.
Yo
Pero
comprendo.
entonces, pero
Desagradável.
entonces, pero entonces quiero decir que sí se podría utilizar para este tipo de sistemas, pero en nosotros observamos que a 2,5 milihercios no puedes obtener depolarización neuronal, por lo tanto, a menos que añadas otra señal, no tiene sentido el utilizarlo. Eso es para tratar de contestarle a Francisco. De nuevo, gracias por la pregunta. Si tienes alguna otra, yo estoy mirando el chat hasta que terminemos. ¿Por qué no estimulo al paciente cuando está acostado? Te voy a decir un pequeño secreto, ¿vale? Nosotros, desde hace muchísimos años, a mí se me metió en la cabeza que las parestesias son un efecto secundario, como lo acabo de decir hace un momento. No es el mecanismo de acción, y es lo que he tratado de demostrar a nivel molecular con todos mis estudios. Ahora, diciendo eso, durante el estudio, nosotros aumentamos, porque la indicación, la forma en que está el labeling de Medtronic para el estimulador, tienes que tener parestesia durante el trial phase. Entonces quiere decir que mientras está en la mesa, nosotros lo que hacemos es aumentar la amplitud hasta que el paciente dice, siento algo. Ah, bueno, fenomenal. Hemos terminado, vámonos para afuera. La verdad es que no necesitarías ni hacer eso, pero nosotros lo hemos hecho. Algo que me parece importante y es, nosotros hicimos un estudio, lo hicimos con High Frequency, que lo publicamos, y otro que hicimos dentro de nuestro estudio con los pacientes. era muy frecuente encontrar pacientes con dolor radicular de la pierna izquierda, a quienes cuando tú aumentabas la amplitud dentro de los bipolos que ibas a utilizar para la estimulación, el paciente sentía estimulación en la pierna derecha, en la contralateral. Es decir, la presencia de las parestesias en un sitio u otro no determinan el beneficio de esta terapia. Tú me podrás decir, y yo estoy de acuerdo, oye, yo prefiero programarlo mientras está en sala de cirugía y que tenga parestesias donde le duele, por si acaso. Oye, yo soy un científico supersticioso. Yo, o sea, tú me dices, a mí pasa por debajo una escalera. Yo no paso. O sea, no me hagas pasar por debajo de la escalera porque no lo hago. Diciendo eso, creo que no tiene nada de malo que lo hagas, pero la programación para los ECAPs tiene que hacerse con el paciente sentado. El paciente se le hace que se eche para atrás, se hace que se le eche para adelante, pero quizá estoy de acuerdo, José Luis, que si no te molesta perder 20 minutos de más programando, oye, fenomenal. O sea, uno nunca sabe qué es lo que va a funcionar. En nuestros estudios no hubo ni un solo paciente que fallase con terapia subperception, que cambiase a terapia con parestesias y tuviese éxito. Ni uno, cero. Y son casi 400 pacientes en la suma de todos los estudios. Eso no quiere decir que tu paciente no vaya a responder. Y si es, oye, al final este hombre ha confiado su vida en ti por 20 minutos, oye, por, by all means, o sea, yo haría lo mismo, totalmente.
Gracias, gracias. Ángel, Sisa, una pregunta más.
Sí, bueno, de acuerdo con eso, a veces los pacientes sí se sienten más cómodos si sienten la parestesia cuando se hace la prueba en donde a ellos les duele, porque si lo sienten en la otra pierna, a lo mejor piensan que estamos hasta equivocados trabajando otro lado, ¿no? Se apoyan con psicología también para entonces tratar de reducir ese estrés o esa ansiedad con los pacientes.
Súper importante lo que acabas de decir, Ángel. Dos cosas quiero, dos comentarios tengo. Uno, yo nunca les digo a mis pacientes que van a tener, bueno, perdón, yo nunca uso DTM y jamás lo utilicé porque me parecería una falta de respeto a mis pacientes, porque seguramente estaría sesgado. Entonces nunca lo he hecho. Que conste que hoy en día tampoco hago estimulación, excepto en mis ratas y cuando voy a España. Eh, pero si tú a un paciente le dices, usted va a sentir parestesia en las zonas de dolor, lo cual determina que usted mejora, ese paciente no te responde. No te responde a nada. Te voy a decir por qué. Porque el paciente, y nosotros tuvimos un paciente que es el único que yo sé, el cual de vez en cuando subía la amplitud de la estimulación. Y nosotros decíamos, ¿pero para qué lo hace? Sí, porque no quiero que me estén engañando y que esté apagado y yo le estoy diciendo que no tengo dolor y está apagado. Entonces, por esa razón, este paciente lo hacía. Nosotros encontramos que si al paciente le hablabas de parestesia, de esto, esta tuve una charla muy interesante con Juan Felipe en Colombia hace ya años, pero si tú a un paciente le dices que va a mejorar porque las parestesias, yo no sé qué hablan ustedes con los pacientes, yo no sé si tú le hablas de la teoría de la compuerta y todo esto. El momento en que tú le hablas de la teoría de la compuerta como explicación y el paciente no tiene parestesia, lo primero que va a pensar es, esto no me sirve. Y yo te aseguro que si tú tienes un paciente en el que no le sirve un subthreshold stimulation, le estás reduciendo un 80% de chances de que mejore solo con la tónica. Eso no quiere decir, como decía antes, que no vayan a mejorar, pero yo hago lo opuesto. Y les digo, es posible que sienta algo, no se preocupe, simplemente estamos calibrando la amplitud y no quiero que se sienta mal con la estimulación que le estamos aplicando. Hemos visto que lo opuesto, si el paciente cree que necesita las parestesias más aún que macheen el área de dolor, es una condena básicamente a decir que no van a responder estos pacientes. Y por último, el otro comentario que quería hacerte es que si yo he algo aprendido en los últimos 27 años, 28 años, poniéndole agujas a todo el mundo, viendo pacientes que son operados, poniendo cables de estimulación, poniendo bombas de infusión y todo esto, no hay nada mejor que cogerle la mano al paciente y decirle que estás a su lado. Eso yo creo que es algo que la mayoría de nosotros que llevamos un tiempo en el campo lo sabemos. Nada mejor que un buen placebo. Darle un abracito al paciente de vez en cuando, decirle que no pase lo que pase, vas a estar a su lado. Eso es mucho mejor que el DTM y que cualquier cosa. Entonces, tienes toda la razón, Ángel. Hay que tener cuidado cómo se utiliza el placebo. Yo personalmente adoro y admito que adoro el efecto placebo porque es quizá una de las mejores armas que tenemos como médicos.
Muchas gracias.
No, a
Cisa,
ti, Ángel.
Cisa,
Bien.
¿no? Sí. Gracias, amigo. Gracias, Ricardo, por sua presença acá com nós outros. Você é muito importante para nós outros acá. E, e você havia falado sobre Ribeira del Duero, que é uma
Ah,
região muito importante de vinho em Espanha. E disse muito bem sobre Vega Sicília, que é um produtor muito importante. O vinho mais importante é o único que quando sale a primeira botija ela vai para o rei de Espanha, sempre.
y de Inglaterra.
E de Inglaterra, sim. E queria saber de você, desta que é tão impressionante, é um vinho especial, comparado com Pingos, um concorrente da mesma região, Pingos e Único. O que prefere?
A ver, espérate, es que te voy a hacer un pequeño viajecito por mi casa, perdona. Espera un momentito. Ah, espérate, que es que voy a enseñarles mis vinos.
Quero vê-los.
A ver, este es mi cellar, muy al estilo Miami.
Sim,
Y entonces tú me estás hablando de este vino que es el único. No, no sé si lo alcanzas a ver, pero esta es una
sim,
botella de único,
Mhm.
sim,
¿vale?
perfeito. Sim,
Ahora, dentro de eso, Vega Sicilia tiene otros, como es este de aquí arriba, que es el Valbuena,
sim.
y quizá el que tú me estás hablando es el Pintia.
No, Pingos, Pingos.
Pues yo conozco, mira, he aprendido algo. Tengo Valbuena, Pintia, Único y tengo Macán.
Sim,
Pero ese Pingos no lo
esse.
conocía.
Ah, sim.
Así
Mira,
que cuando
e-
vaya a Brasil en marzo, creo que es en marzo, no sé cuándo es.
Sí,
Cuando
sim,
vaya a
março,
Brasil,
sim.
eso, nos tomamos una botella de Pingos
De
y así
Pingos,
aprendo.
perfeito. Perfeito. Muitas graças, amigo. Muitas
A
graças por
ustedes,
tudo.
muchas gracias a
Sí.
todos.
Buenas noches.
Va. Buenas
Buenas
Hasta
noches,
luego a
noches.
chao.
todos. Hasta
Un
luego.
Chao,
abrazo.
chao.
Chao,
Un
chao.
abrazo, Ángel, un gustazo verte,
Bye.
Cecilia.
Sim, sim.
Igual.
Chao.
Tudo bem, pessoal. Muito obrigado, viu? E vamos aí, um painwine maravilhoso, com tantas informações importantes aí. O Ricardo Vallejo é uma pessoa especial, pesquisador do assunto. Muito obrigado. Um beijão para todos aí. Ótima noite. Tchau aí.
Muito
Tchau.
Chao.
obrigado.
Hasta
Chao.
luego. Chao.
Chao, chao.